Hi, in this video we'll break down two high-yield pediatric GI cases presenting with vomiting in neonates and infants. We'll learn how to identify essential clinical signs, interpret key lab findings, and recognize hallmark imaging features. A 9-day-old male infant is brought to the hospital due to sudden onset greenish vomiting, blood-stained stools, and progressive abdominal swelling over the past several hours. His parents report he has been unusually sleepy and irritable. He was born at term via uncomplicated cesarean section and had no issues during the initial hospital stay. On examination, the infant is febrile and tachycardic, with a blood pressure of 60/35. His abdomen is distended and tender to palpation. A contrast-enhanced upper gastrointestinal series reveals the duodenojejunal junction located abnormally on the right side of the abdomen with a corkscrew appearance. What is the most likely diagnosis? A. Duodenal atresia. B. Intussusception. C. Necrotizing enterocolitis. D. Pyloric stenosis. E. Volvulus. The correct option here would be E. Volvulus, and that is because this neonate presents with classic signs of mid-gut volvulus due to intestinal malrotation, bilious vomiting, abdominal distension, lethargy, and signs of early shock. Now, the greenish vomiting mentioned in the question indicates the presence of bile, and this confirms that the vomiting is bilious in nature. Volvulus most commonly occurs in infants under 1 month of age, and it occurs when the bowel twists around the superior mesenteric artery, leading to bowel ischemia. Blood-stained stools indicate mucosal injury, while tachycardia reflects a compensatory response to hypovolemia and evolving shock. The corkscrew sign on imaging indicates a malpositioned, twisted duodenum. Let's have a look at why the other options are incorrect. Option A is incorrect because duodenal atresia often presents in the first 24 hours of life with bilious vomiting. But you will see a double bubble sign on X-ray and not a corkscrew sign. It's also not associated with bloody stools or signs of shock, so this isn't the correct answer. Option B is incorrect because intussusception usually presents in older infants and not in neonates. It usually presents between 6 months of age to 3 years, and the classic signs include colicky abdominal pain, intermittent crying, and current jelly stools. Diagnosis is made with ultrasound or contrast enema, which may show a coiled spring on the imaging. And option C is incorrect because necrotizing enterocolitis is common in preterm infants, often showing as pneumatosis intestinalis on imaging. While bloody stools and lethargy are common in necrotizing enterocolitis, this baby in this question is a full-term baby, and the contrast study findings are not consistent with necrotizing enterocolitis. And option D is incorrect because pyloric stenosis presents around 3 to 6 weeks of age with non-bilious projectile vomiting due to an obstruction above the duodenum. You might see the string sign on imaging, but there is no bilious emesis or a corkscrew pattern seen on imaging. So this option is also incorrect. A 4-week-old infant is brought to the clinic due to concerns about persistent vomiting. The parents report that over the past 2 weeks, the baby has been spitting up after feeds, which has now progressed to forceful projectile vomiting of non-bilious fluid. The infant appears hungry after vomiting and eagerly feeds again. On examination, the baby appears dehydrated and a firm olive-shaped mass is palpated in the epigastric region. His weight is below the 25th percentile. Which of the following findings is most likely on laboratory evaluation? A. Hyperchloremic metabolic acidosis. B. Hyperchloremic metabolic alkalosis. C. Hypochloremic metabolic acidosis. D. Hypochloremic metabolic alkalosis. E. Normal electrolyte and acid-base levels. The correct option here would be D. Hypochloremic metabolic alkalosis. The clinical picture is consistent with pyloric stenosis. Now, pyloric stenosis is narrowing of the lower portion of the stomach that leads into the small intestine, causing gastric outlet obstruction. Repeated vomiting of gastric contents, which is rich in hydrochloric acid, causes the loss of hydrogen and chloride ions, resulting in metabolic alkalosis and hypochloremia. Prolonged vomiting may also lead to hypokalemia. Now, hypokalemia will develop from a combination of increased renal activity of the hydrogen-potassium pump and increased bicarbonate in the serum, causing potassium to be taken up by cells in exchange for hydrogen ions. Let's have a look at why the other options are incorrect. Option A is incorrect because hyperchloremic metabolic acidosis is usually seen in loss of bicarbonates and which happens in cases of diarrhea and not vomiting. Vomiting causes loss of hydrochloric acid leading to alkalosis. And option B is incorrect because alkalosis is expected in this question, but hyperchloremia is not. Vomiting leads to chloride loss, making hypochloremia more likely. And option C is incorrect because while hypochloremia may occur, the metabolic disturbances in vomiting is alkalosis and not acidosis. And option E is incorrect because given the prolonged vomiting, it's unlikely that the infant's labs would be normal.